Department of Medicine Grand Rounds. So one of the most exciting parts of my job on Thursday mornings is to celebrate our own, and this is one thing that we're going to do today. As you see, we're here celebrating Dr. Neustadt, David Neustadt. And so every year we come here to do this for a number of reasons. We're looking for people who are accomplished, but the fact of the matter is that we're looking for more than that. We're looking for inspiration for our trainees, for our junior faculty, for our colleagues. We don't live in easy times, and yet I'm sure that the people that came before us and they're still continuing without also encounter very difficult times, and yet we're able to leave a tremendous legacy. And that's what we celebrate. No? So let me just tell you a little bit of Dr. Neustadt before I bring Dr. Roberts to introduce our special guest. So, born in Evansville, Indiana, not too far off, went to DePaul University for undergraduate and then did medical school here at the University of Louisville, did his internship and residency in New York, and then went on to the National Institutes of Arthritis and Metabolic Disorders, where he did a fellowship there, did a detour for GI, I'll leave that out, came back, and then started in Louisville since 1954, and developed a career as a rheumatologist and immunologist in this area. He has been involved in active and important posts in multiple national organizations, particularly the American College of Rheumatology, but he's also been extremely active locally. He was chief of one of the original arthritis clinics at the Louisville General Hospital. He was also section chief for rheumatology at the School of Medicine for over 15 years, and I can go on with the multiple positions he's had and the people who he has assisted throughout the years. He has contributed greatly to the literature with over 150 publications and multiple presentations here and abroad. And don't take it from me. He has been awarded by a number of organizations for his effort. He is a fellow of the American College of Physicians and the American College of Rheumatology. In 92, he was named a master of the ACR. In 97, he was honored by the American College of Rheumatology as a Distinguished Rheumatologist Award, a recognition for his outstanding achievements in the field. And so with that, a fund was created to celebrate him and celebrate academic medicine. So every year we bring an accomplished, outstanding academician in this area to continue to remind us about the legacy of Dr. Neustadt, but the legacy that each and every one of you who are sitting in this room will develop over time. And with that, I leave you, Dr. Roberts, to introduce our special guest.
Thank you. This is going to be fun. So this morning we have Sterling West. Dr. West is the Associate Chief of the Division at the University of Colorado, and he's in charge of the clinical education piece, and he's probably one of the best known clinical education people in rheumatology in the United States, possibly because of this book here, which he wrote, which is The Secrets. It's a study guide for boards now, although it wasn't originally conceived that way. And this is something that every rheumatology fellow has, basically, possibly 2 copies if they've been studying long enough. And it's probably, I think, maybe the second most read, it could be the most read rheumatology book that there is in the United States. So Dr. West, I should mention, has been to Emory, which sometimes sends us good people, and he's been to a number of other places, including West Point, and did 24 years in the military. He's colonel in the Army, actually, and really well versed in this particular area, sarcoid, and also CNS lupus and some other obscure areas.
Well, thank you, Neil. It's a real pleasure to be here. It's a particular honor to give this particular lecture because I have a personal connection that I'd like to share with you. It's actually a true personal story. So many years ago, and this was before the internet, before cell phones, before personal computers, a 31-year-old U.S. Army major, i.e. me, who recently graduated from a rheumatology fellowship, was assigned to Fitzsimmons Army Medical Center in Aurora, Aurora, Colorado. Within the first month of arrival at Fitzsimmons, the commanding general's aide called me in the middle of the night at 2 a.m. and said the general had a swollen right ankle and he needed to see me now. And you don't say, well, maybe in the morning. No, it means now. So I arranged to see him in the emergency room. The only problem was that during my fellowship, I actually had never tapped an ankle. And so my first ankle was going to be the commanding general of my hospital. Well, on my way in, I stopped off in my office, and I knew that I had this book here. And this book was sort of my Bible on how to aspirate and inject joints. And you can see that Dr. Neustadt is co-author of it. And I looked at the page 91, and this is all I had. All right, and I said, well, that looks pretty easy. I'll just go in there. All right. So I went in, and I successfully aspirated the joint and caused the general minimal pain, but I gave him a lot of lidocaine, I think. And the synovial fluid was inflammatory, had uric acid crystals, a negative gram stain, which at that time we did ourselves, and so we made the diagnosis of gout. So now the question was how to treat it. Well, I could give him nonsteroidals and cause him to have an upset stomach. I could give him colchicine and he'd have diarrhea for the rest of the night. I could give him oral prednisone, but I had done one tap, so I was an expert. I figure I'll just go ahead and do another tap, all right, and inject the joint. And I did, and he got better, and he was my best buddy for the rest of the time. So thank you, Dr. Neustadt, for saving my military career. So it's a real pleasure to be able to talk at Grand Rounds on sarcoidosis. This has actually been an interest of mine for quite a while, and I'll tell you how we got into it. But it really applies to Grand Rounds because it touches so many different subspecialties, not just rheumatology, pulmonary, basically all of them. So the University of Colorado is very happy that I have no relevant financial disclosures. These are some references, and hopefully the chapter will be out this year. And what I want to do is talk about the common and uncommon presentations, describe how we evaluate people with sarcoid, and discuss the existing treatments. Well, the title is Sarcoidosis from Hutchinson to Russell. And Hutchinson was a dermatologist, or Jonathan Hutchinson, in the 1800s. All right, I think Dr. Kalin knew him well. And he saw at the Blackfriars Hospital in London a patient who worked on the wharfs unloading coal, and this patient had these unusual skin lesions that he actually thought originally was atypical psoriasis. But back in that time, what they would do is they had to be artists, and he basically did a picture of it, and 10 years later actually put it in a famous book. And a few years after that, he actually saw another patient, Mrs. Mortimer, and had similar types of lesions, and he called that Mortimer's malady. So you may have heard it referred to as that. Well, in 1899, Dr. Cæsar Beck, who was a Norwegian pathologist and dermatologist, called this condition sarcoid, since the skin lesions resembled these benign tumors. And at that time, sarcomas were what were called benign tumors, different than today. And it comes from the Greek, sarco meaning flesh, eidos meaning like, or anosis, condition. And he also described the pathology, showing the non-caseating granulomas. So as you know, sarcoidosis is a disease of unknown etiology. It's characterized by these very compact granulomas, okay, that are very characteristic. And you also have to rule out other causes of granulomatous disease. The thing that's great is that it's the great imitator. It can present a variety of different ways, all right? So it's actually a fun disease, and Dr. House, would say that even if you bust your toe, it could be sarcoidosis. That might be a stretch, but again, it needs to be in your differential, okay, of however they present. And with that in mind, here's a case that we were involved with. So LG is a 56-year-old Hispanic male transferred from an outside hospital for increasing bilateral lower extremity weakness and falling for the past 6 months. Past medical history was that he had been diagnosed with multiple sclerosis 4 years previously, and he had lower extremity, more and upper extremity weakness and a neurogenic bladder. Notably, he was a non-smoker. Physical exam showed vital signs were normal. The neuro exam was the most abnormal thing with impaired conjugate gaze. Upper extremity strength was 4 out of 5. Lower extremity was much worse. He had a shuffling gait. He had some vibratory abnormalities, no deep tendon reflexes, and had a suprapubic catheter. Lab showed a CBC with a crit of 37, white count okay, and platelets all right. CMP was normal except for a slightly low albumin. TSH, CK, FOS, MAG, all normal, and UA was consistent with having a catheter in. Well, laboratory-wise, his ANA came back 1 to 160, and that's how we got involved. All right, so he was on neurology, but because of the positive ANA, we were asked to see him. Rheumatoid factor negative, other serologies negative. VITE-D was normal at both the 25 and the 125. Notably, the ACE level was normal. SPEP had a mild polyclonal gammopathy, but the CSF was wildly abnormal. Cell count 104, mostly lymphs. Protein very high at 426. Glucose very low at 13. Immune studies showed a high IgG index and oligoclonal bands, and that was the reason he was originally called multiple sclerosis for the past 4 years. Chest x-ray notably was normal, and this is a picture of it, and you could, in retrospect, say, well, there might be a little fullness there, but even in retrospect, it looked pretty normal. His brain MRI, though, was quite abnormal, and it showed this basilar enhancement, basilar meningitis, okay, occurring around the brainstem, okay, in lower areas of the brain, as well as the enhancement, okay, the upper part of the cord to account for his multiple neurologic abnormalities. So the question is, what would you do now? Would you get an ophthalmologic exam? Would you get a CT scan of the lung? Would you do an ACE level on the CSF? Would you do a brain biopsy? Would you do a bone marrow biopsy? Okay, how would you make this diagnosis? Because it's pretty difficult, okay, when they present this way. So hopefully we'll answer that at the end. So keep that in mind. So sarcoidosis, okay, again, age, younger age, 20 to 40. Second peak in a little older women. Can affect all ages, sex, females a little bit more. There is a familial clustering suggesting that there can be a genetic component. There's a seasonal clustering suggesting there can be an infectious cause. And of course, there's occupational clustering, environmental exposures such as the coal that the wharf worker in Hutchinson's day may have been exposed to. It occurs worldwide, but there is a difference, okay? As you start at the equator, it's a little less common, but as you go up all the way to Denmark, it's quite more common. The United States, all right, is seen more in African Americans than other races. And in fact, the incidence is about 2.4%, or the prevalence 2.4% for African Americans. That's screamingly high. All right, only 1% of the population has rheumatoid arthritis. Less has SLE, 2.4%. Okay, it should be on your differential quite commonly. This is where I got interested in it, and this was when I was at National Jewish Hospital in Denver before going to the University of Colorado, and they were part of this 10-center trial that was NIH-sponsored, trying to figure out the etiology, okay, of sarcoidosis. And I was the token rheumatologist, okay, that was involved at the National Jewish. And the clinical manifestations, again, the ACCESS trial, in order to get into it, okay, you needed to have lung involvement, so that's why it's so high. Overall, though, if you look at other large series, okay, you find that the lung is the most common presenting manifestation, and over time will become the most common overall. But there are a variety of other manifestations that they can actually present with. And again, in these manifestations, you need to consider sarcoid in your differential. Now, notably, the organ involvement is defined early in the disease, okay? And actually only about a fourth or 25% of patients will develop other organ involvement over the next 2 years. So again, it's not everyone that will progress. Again, some of the more or less common ones, but the ones that will actually contribute to their demise are neurologic and cardiac, and really something that needs to be on your radar. Now, depending upon the race, there can be differences in presentation. So Caucasians like to get Lofgrens in particular. People of Japanese extraction like to get cardiac and eye involvement. So again, Asian patients with sarcoid have a higher risk for cardiac disease, and that needs to be kept in mind. African Americans in general have more widespread and severe disease. Again, there can be sex differences, there can be age differences in the clinical manifestations. So if we look at all sarcoidosis and how they tend to present, you can say that 5% are asymptomatic. It's just picked up on a routine chest x-ray, all right? And we, don't know, or they do actually pretty well. Where we tend to get involved as rheumatologists is the acute sarcoidosis, okay, where they come in with the so-called Lofgren syndrome with arthritis, enodosum, and bilateral hyaluronopathy. And depending upon the series, that can be as high as 20% of them. It's the subacute chronic onset, okay, that you're probably most familiar with, and this is pulmonary predominant in the majority, and more of them are going to present to the pulmonologists who are clearly expert. But at least 50% of the people that have pulmonary involvement will have extrapulmonary involvement. And again, that's where we tend to get involved. But it's this 30% that have predominantly extrapulmonary involvement. And it may be their only involvement that can be particularly diagnostic challenge, much like the case that I presented. So with pulmonary sarcoid, okay, it occurs in over 90%. 50% have an asymptomatic chest x-ray. The other 50% have symptoms. Dyspnea and dry cough are the most common manifestations. If you have wheezing, you have to worry about endobronchial involvement, and that can be a particular problem. Hemoptysis is rare. If somebody's coughing up blood, if they have sarcoid, they usually have aspergillomas. If they have other lung disease, it's not going to be sarcoid if they have alveolar hemorrhage. Lung crackles are fairly rare. Clubbing is very rare. And pulmonary hypertension, though, we're finding is more common than previously explained or previously appreciated. And it tends to correlate with dyspnea. So if we have somebody with sarcoid that has severe dyspnea, really everything else doesn't look that bad. Pulmonary hypertension has to be a consideration. So with the pulmonary evaluation, the chest x-ray, we have the modified scanning staging system. Stage 0 is a normal chest x-ray, but keep in mind they may have an abnormal high-resolution CT scan, so something to consider getting even with a normal chest x-ray. Stage 1 is just bilateral hyaluronopathy. Stage 2, okay, is bilateral hyaluronopathy with interstitial changes. Stage 3 is the just interstitial changes, and stage 4 is honeycombing. Now, the thing to realize is that these are not progressive. So you don't go from stage 1 to stage 2 to stage 3. All right, what your stage is what you start out with. It may get worse, okay, but it isn't that this is a natural progression. With our evaluation, PFTs usually get a restricted pattern. Again, if you have obstructive, we worry about endobronchial lesions. There is a poor correlation between the dyspnea and the PFTs as well as the high-res CT scan. So again, if you have somebody with severe dyspnea on exertion ruling out pulmonary hypertension or heart involvement is particularly important to do. Some people are set up to do bronchoalveolar lavage. If you do have that, okay, they tend to be lymphocyte with a high CD4 count. And then the transbronchial biopsy, even with a normal chest x-ray, it can be abnormal. But obviously with an abnormal chest x-ray, it tends to be more likely you'll get a positive biopsy. And the fine needle aspiration, okay, ultrasound guided, is particularly beneficial, particularly if you have hyaluradenopathy. Now, we have a rheumatologist actually embedded in the pulmonary clinic. They actually talk to them. All right, and they, if somebody comes in with a variety of different diseases that might be related, okay, to sarcoid as well as the connective tissue disease, they're often consulted. Same thing with ophthalmology. We have a rheumatologist embedded in ophthalmology, all right, in that they have a particular interest in this area, and patients, again, that present with a variety of different diseases, including sarcoid, frequently get evaluated by the rheumatologist. So with sarcoid, the eye involvement can be the initial manifestation in 5%. Now, uveitis is the most common, and it's typically bilateral, which separates it out from HLA-B27 disease. But in addition, all right, these patients can have no symptoms whatsoever. And again, that's important, okay, in your screening, is to realize that you don't have to have symptoms and still can have sarcoid of the eye that needs to be evaluated. So with our sarcoid involvement of the eye, if it's the anterior chamber, okay, you do a slit lamp exam and you see these mutton fat keratitic precipitates. Now this is characteristic of granulomatous uveitis, and what these are white blood cells with fat that just sort of stick to the back of the cornea, and you can pick that up with slit lamp examination. Again, they can get an inflammatory response that may be symptomatic, but many times these are asymptomatic. You can also get middle chamber involvement of the uveal tract, and they get this sort of snowball or string of pearls, okay, and they typically have symptoms of floaters. And then with posterior chamber, this is what will cause blindness, okay, where you have retinitis and vasculitis of the posterior retinal area. And one of the most fun areas to be involved, okay, is the dermatologic manifestations. And again, we have a close relationship with derm, so that we, again, tend to share these patients. There are specific skin lesions, okay, and then there's non-specific skin lesions. Specific skin lesions are particularly these macular papular lesions like the nape of the neck. Again, when you biopsy them, they have these well-formed granulomas. One of the more interesting phenomenon with sarcoid is that they like to occur in areas of trauma, particularly tattoos, okay? And so here's a tattoo that has sarcoid in it. I think it's supposed to be a seahorse. I'd probably ask for my money back, all right? But again, very, very common. But again, sometimes they occur in incredible tattoos, all right? And somehow people with tattoos don't like 3D tattoos, all right? And so these patients, okay, actually had a history of uveitis that had not been diagnosed, and they went and got a tattoo, and they were very unhappy with the outcome, all right? So again, that can be a clinical clue. Another specific lesion is lupus pernio. Again, it goes across the face, resembling maybe the malar rash of lupus. Also looks a little bit like rosacea or seborrhea. Puerto Ricans are particularly prone to getting this, and a lot of times they'll have underlying sinus involvement. You can get annular plaques that, again, are, when they biopsy, they have very granulomatous lesions. And then here are the purplish plaques, very reminiscent of what we showed with Hutchinson's patient way back in the 1860s. Now, one of the more common lesions that everyone might associate, okay, with sarcoid is enodosum, but that's a nonspecific lesion because there's many different lesions that can, or many different diseases that can cause enodosum. The enodosum is the anterior part of the lower legs. Does not occur on the posterior part. When you biopsy it, which you rarely have to do, but if you do, it's a septal paniculitis as opposed to a lobular paniculitis. And the thing about all these sarcoid lesions, keep in mind, okay, is that they don't ulcerate. If you have lesions that are ulcerating, okay, it's probably not going to be sarcoid, and you should think of other diseases. Now, obviously, the most important involvement is the musculoskeletal. All right, but joint involvement, okay, is one to keep in mind that they can have the so-called Lufgren syndrome with acute polyarthritis that can precede other manifestation by months. The key is the ankles. All right, if you have bilateral ankle arthritis, you should think sarcoid. Okay, so again, even without enodosum, because they may not have the other manifestations of the Lufgren syndrome. So if you have bilateral ankle arthritis, and it's more of the periarthritis, it's incredibly painful. All right, you got to get a chest x-ray. All right, that's your next step. All right, so again, that's a clinical pearl to keep in mind. Now, most of them, because they don't have lung parenchymal involvement, the ACE level is going to be normal, but sometimes the ACE level is high, the angiotensin converting enzyme. And we actually find that helpful, although that might be debatable. But in this group, those that have high ACE levels are more likely to have recurrence or prolonged courses of their Lufgren syndrome. So we're more likely to go to steroids a little quicker, okay, in those particular individuals. And I also, from personal experience with my son, who I told should not go caving, he presented, okay, with acute histo. That's the one thing you have to rule out. They can have the enodosum, the arthritis, the pulmonary involvement, okay, and can mimic Lufgren syndrome quite well. So again, very painful, bilateral ankle arthritis, okay, and again, the enodosum. Now with chronic arthritis, okay, this is less common, and you're going to have obvious sarcoid everywhere, all right, when a patient presents with the chronic arthritis. So it's really not that difficult a diagnosis. Here, because it's more of a synovitis as opposed to a periarthritis, they will have inflammatory synovial fluid. Okay, if you do a biopsy, you will find granulomatous inflammation. There's a patient that actually mimicked rheumatoid arthritis, but actually the knee is probably a more common area, okay, to be involved, and it'll mimic either gout or a spondyloarthropathy. If you do a biopsy, again, you find these well-circumscribed, non-caseating granulomas with giant cell formation. Bone sarcoid is much more common than you think. All right, again, as far as bone formation, you know, symptomatic bone is actually relatively rare, and when it does occur, okay, it will mimic cancer, you know, with or infection, all right, and you have to go and do your biopsies. But if you do the scanning, okay, of MRIs, PET, or bone scan, you'll actually find a lot more sarcoid in bone marrow, okay, throughout the skeleton. And again, over 33% of patients will have silent bone lesions. Now, with the most common bone lesions, or more characteristic ones, are out here in the hands. And again, these patients tend to get these cystic changes or granulomatous reactions that occur. A lot of them will have these characteristic sarcoid skin lesions over top, which sort of indicates that you'll have involvement of the bone underneath. Now with the muscle, okay, again, the muscle involvement can be a problem. Okay, if you biopsy randomly muscles, you'll find sarcoid not uncommonly. But as far as symptomatic lesions, okay, one that we particularly dislike seeing is chronic myopathy of sarcoid. The problem is that they don't respond to anything, right? You know, again, it's just a particularly difficult presentation to get control of. So the chronic myopathy is very, very resistant to therapy. The acute myopathy that looks like polymyositis is exceedingly rare, okay? So again, should not be really high on your list of differential. Muscle nodules, though, can be seen, and if you do an MRI, you find this dark star, okay, where it's get black with this surrounding edema pattern. Vascular involvement can occur with granulomatous inflammation of the vessel walls. They can actually look a little bit like Wegener's and like, but they're going to be ANCA negative. Okay, so again, your anti-neutrophil cytoplasmic antibodies will be negative. Now, what's going to kill them is the cardiac involvement. All right, and again, no matter how they present, this has to be on your list of consideration. So it can be the first manifestation. It can affect any area of the heart. And anybody that's complaining of palpitations or orthopnea near syncope, okay, you have to really look at these patients, evaluate them to get all their, to make sure they don't have involvement of the heart, because the arrhythmias, okay, can kill them. And if you have evidence of arrhythmias, we want to put an implantable defibrillator in them to try to prevent the death. Again, this is particularly common in Japanese. Now, so this, because of the importance of that, okay, patients with sarcoid, everyone should have an EKG and be followed, okay, with EKGs, okay, down the way, at least once a year. If the EKG is abnormal, that's a signal that you may have underlying cardiac involvement. And those patients need an echo and they need scanning. And the scanning that is typically done is the cardiac MRI, which shows inflammation, okay, of the vessel wall or the heart muscle. And again, the endomyocardial biopsy is difficult to get a positive biopsy because these lesions tend to not be in areas that are amenable to biopsy. So again, you have to go based on your cardiac MRI. And then neurologic involvement is my personal interest, okay? And that CNS involvement occurs in 5%. It can be the initial manifestation in over half the patients that have neurosarcoid, and it may be their only manifestation. So again, that makes it a particular challenge, okay, to try to figure them out. But anybody that comes in with granulomatosis basilar meningitis, it's the basilar meningitis that should be a key. Just like for tuberculosis, okay, and the like, basilar meningitis should make us think about sarcoidosis. There are a variety of other presentations, including the classic cranial nerve, seventh nerve involvement that can occur. They can have multiple different presentations also, but again, granulomatous basilar meningitis is the thing to keep in mind. And so when we have somebody that has neural sarcoid, we have to try to find an area to biopsy because opening their brain or their skull is difficult to do. And so consequently, we'll go and look at places that are silent. And places that are frequently silent, okay, are going to be the eye involvement and the lung. So even with a normal CT or a normal chest x-ray, you do a high-res CT to see if there's evidence of sarcoid there that you can biopsy, and you send them to the eye clinic for a slit lamp exam, okay, to make sure, see if they have silent involvement there. Again, you do your MRI with gadolinium that's going to show the enhancement. The CSF is going to frequently mimic multiple sclerosis, okay? Now, the thing that's different, though, is that you have too many cells. So they tend to have more cells. They'll have an elevated protein. Glucose can be low, but it's the elevated IgG index, okay, and oligoclonal bands that can fool people. But it's just a manifestation of the active disease or the active immune disease that they have going on. So here's some examples, okay, of sarcoid that they can have these mass-like lesions that can mimic metastatic disease, okay, and these cystic lesions also. The other manifestations that can occur with sarcoid are involvement of the lymph nodes. They can have adenopathy. They can have hepatosplenomegaly. hepatosplenomegaly, okay, and whenever a sarcoid patient has a low white blood cell count, platelets, hepatosplenomegaly, particularly the splenomegaly, has to be a consideration, or bone marrow involvement. Now, the upper respiratory tract can be involved. This is a cause of saddle nose deformity. They can get enlargement of their parotid glands mimicking sarcoidosis. Okay, this has to be a consideration. But we're all familiar with the calcium abnormalities that they can have, and this is from an overproduction of the 1,25-hydroxy by D because of an autonomous production of 1-alpha hydroxylase within the granulomas. Now, what this does is increase intestinal absorption, and if for a while you'll get rid of that extra calcium, okay, through your urine. Okay, so you want to always get a 24-hour urine to see if they have hypercalciuria, because they can have that without having hypercalcemia. Other involvement is less common, okay, but virtually any organ can be involved. Now, the other thing to keep in mind with sarcoid is it can coexist with other diseases. It doesn't have to be its own disease. And so we've published a series, okay, on its association with other autoimmune diseases, and this can be a problem because RA, lupus, Sjogren's can all have interstitial lung disease, all right, but you have to consider sarcoid, okay, as a cause, a correctable cause in those individuals. The other one that'll burn you is the common variable immunodeficiency. So again, anybody with sarcoid, you need to at least look at some immunoglobulins, make sure that they don't have hypogammaglobulinemia, since sarcoid patients should have increased gamma globulins, not decreased ones. And then there are case reports, and we've actually caused sarcoid in a few of our patients with our anti-TNF-alpha therapy. So again, certain medications have been associated, okay, with causing sarcoid lesions. So when you see your patients initially, okay, there's a recommended workup, okay, that needs to be done. All right, and this is pretty standard, okay? So you do your history with environmental and medication occupational exposures, physical exam, chest x-ray, PFTs, blood counts, serum chemistries, vit Ds, CK, urinalysis, 24-hour urines, and here EKG. Everybody gets an eye exam, okay, and then biopsy is necessary. So with your lab tests, okay, you expect to see anemia, chronic disease. You do not expect to see low white counts or low platelets. It's usually going to be something else, or you have bone marrow involvement. Chemistries, you can have the calcium abnormalities. Serologies, the SED rate, CRP, is typically up from the hypergammaglobulinemia. The ANA rheumatoid factor may be positive, but it's going to be very low titer, and the ANCA is negative. So there is a question about the importance of getting ACE levels. If you're in the eye clinic, they love lysozyme. Okay, it's basically different cells, okay, making these in response. Now, the thing is, the sensitivity and specificity are modest, okay, at best. You can have a high ACE level, okay, and a normal lysozyme, or vice versa. You can have an abnormal lysozyme with a normal ACE level. The thing about this is that there are very few false positive elevations, okay, for ACE levels. So when it is elevated, it sort of says, well, maybe it's sarcoid. But we actually don't get too excited unless the ACE level is 2 times the upper limit of normal. Okay, so when it's that high, your differential has become much less. So you get sarcoid, you ought to be able to tell if they're hyperthyroid. And there's still the other granulomatous diseases. But you're going to, on occasion, get patients that clearly don't have sarcoid. All right, but somebody has ordered an ACE level, and it comes back screamingly high. All right, 4 times the upper limit of normal, and then you get that consult, all right, and say, what is that? Keep in mind that there is a genetic polymorphism that gives an asymptomatic elevation of ACE that you can test for, okay, and explain why it's high. And that is one of the reasons why the specificity and sensitivity is not as great in this for ACE levels. Again, you can do bronchoalveolar lavage, looking for the increase in CD4 counts. We do the high-res CT scan that can be abnormal even with normal chest x-ray, and then these other MRIs and the PET scan are particularly useful to find areas for biopsy. And we tend to do a PET scan, okay, in people where we have, we think, God, it could be sarcoid. We just can't find a place to biopsy. All right, and those individuals will try to get a PET scan. If we do, we're likely to find an area we can go after, and it's particularly in the bone marrow, okay, that we'll find the PET scan lighting up. When we biopsy, tissue biopsy is the gold standard. It's seen these well-circumscribed granulomas, okay, that are very characteristic. Again, depending upon the area that you biopsy and its involvement, okay, that's the chance of getting a positive biopsy. The Cavine test is no longer done. Now, when I get a positive biopsy, I always go to this slide. Okay, I got it pasted on my wall because there are a variety of other things, okay, that can give you non-caseating granulomas. All right, and you have to rule those out. You can't just say that it's sarcoid. It's particularly in the liver. Okay, the liver. The only way the liver knows to react to anything, it seems to be, is to get non-caseating granulomas. All right, so again, fever. You biopsy a liver and you get non-caseating granulomas. That doesn't equal sarcoid. All right, you have to go through the rest of the workup. So what's our diagnostic caveats, okay, to make the diagnosis? Well, the diagnosis is a combination of clinical findings supported by characteristic histology. But if you have a classic Lufgren's and you've ruled out histoplasmosis, you don't need histologic confirmation. You can make that diagnosis based on that clinical presentation. Atypical cases are people that I'm going to use immunosuppressive medications and I have to confirm sarcoid in one organ, all right, by tissue biopsy. I don't need a second organ, okay, and I can do that clinically, all right, but I at least need one organ to prove that I got sarcoid if I'm going to break out my big gut. All right, so what is the etiology? All right, Dr. Here early on wanted, after 50 years, wanted to know the etiology. We still don't know the etiology. All right, there's thoughts of infections, okay? We can find T cells against mycobacterial antigens. In the Japanese in particular, P. acnes, okay, has been a possibility for causing sarcoid. There are occupational exposures, and interestingly, these water sources tend to have TB antigens, okay, in them, suggesting that there may be a link there. Smoking is protective against developing sarcoid. It's the only good thing about smoking, I think I can tell you, all right? But it's the acrolein and other substances in tobacco smoke that tends to be suppressive, okay, to cellular reaction, okay, and that tends to be protective. So interestingly, our patient that I presented was a non-smoker. Autoimmunity, thought is that whatever kicks off sarcoid causes a consistent immune response, and that you get serum amyloid A, which is an acute phase reactant, and when it misfolds, it cannot be eliminated, and this accounts for some of the sarcoid lesions. And then there's genetics. Okay. So this is sort of our understanding that whatever the antigen is, whether it's infectious, serum amyloid A, or whatever, gets into an antigen-presenting cell, all right, and if you have certain histology or certain genetics, and this is particularly common in the Norwegian, Swedish population, and they're the ones that have the highest chance of getting Lufgren's, you're going to resolve that. Okay, you're going to have an acute sarcoid presentation, and that should go to resolution. On the other hand, all right, if you don't, you present the antigen, okay, to Th1 T cells. There's a release of a variety of cytokines and chemokines, and you get granuloma formation. And depending upon how that evolves in your cytokines, that can either resolve or you can be forced to a chronic or fibrotic disease. Again, this is our understanding, okay, as it stands now. Now, in order to understand the treatment, you have to understand what's the natural history if I don't treat. All right, so only about 25%, as we mentioned, of patients develop new organ involvement in the first 2 years. So we're going to monitor for that, okay, every 3 to 6 months, okay, looking for progression or involvement, okay, every 12 months with an eye exam or EKG. Most patients undergo a spontaneous remission within 3 years. 60% do. Those people don't need to be treated. Additional 10 to 20%, we got to use steroids to get them to go away, to resolve. But they're left with some degree of dysfunction, but they do resolve and don't progress. And then it's this 10 to 30% that have a chronic course, okay? And half of those are going to have lung disease that becomes chronic, and the other half are going to have critical organ involvement, particularly eye, heart, and brain. Now, it doesn't take a wizard to know that poor prognostic signs is the more involvement you have with the most critical organs, you're going to do poorly. The mortality overall is about 5%, and half of them die from the pulmonary disease, half from the cardiac or neurogenic disease. And again, brain involvement and cardiac involvement are particularly bad prognostic signs. With pulmonary disease, if you're in stage 1, okay, you're likely to spontaneously regress. Stage 2, again, likely to regress. Otherwise, not so much. So with our prednisone therapy, the patients with good prognostic signs, we're just going to observe for the first 3 to 6 months to see whether they progress. And people with stage 1 pulmonary disease and normal pulmonary function tests, they really don't need prednisone. Otherwise, okay, prednisone is something to consider. And no one knows the exact dose that should be used, but a lot of times people use 40 to 60 milligrams a day, and then they try to taper it down to 10 milligrams a day by 6 months. The important thing is once you get them down to 10 milligrams a day, you keep them on 10 milligrams a day for at least another 6 months rather than trying to get them off of it too quickly because of the rebound effect that can occur. Now, the absolute indications for prednisone are, again, critical organ involvement, okay, or progression, okay, of disease or persistence of disease in patients that have critical organs involved. Now, what's the indication for immunosuppressive therapy? All right, well, the failure to taper your prednisone down to 10 milligrams by 6 months is an indication. In addition, all right, if you start out with severe disease, okay, with cardiac, neuro, eye involvement in the beginning, you should use immunosuppressions from the get-go, okay, rather than trying to do it all with prednisone. And so we typically, with the more severe disease, cyclophosphamide is our go-to drug, and then we use a less toxic medicine to keep them under control. With moderate disease, okay, methotrexate's been studied the most. We tend to use Celsin MMF, okay, for severe ILD. We love hydroxychloroquine. All right, just like with lupus, I put all of those patients on hydroxychloroquine. I put most of my sarcoid patients on hydroxychloroquine, okay, particularly with the more severe disease. And again, we're a little slanted because we tend to get the worst disease, but hydroxychloroquine actually has some beneficial effects as an immune modulator. It's a pretty benign medication and something that we find particularly effective. Otherwise, we have a lot of other things we can go to, but the one that has enjoyed the most success is infliximab. So if I need another agent for resistant disease, okay, infliximab is what I go to. That's an anti-TNF alpha agent. The reason we use it, okay, is that it's a monoclonal antibody. Okay, I can increase the dose to higher doses, okay, than I can with the other monoclonal antibodies. So infliximab, the other name for it is Remicade. Okay, we use the usual dose for rheumatoid arthritis is 3 mg per kg every 8 weeks to start out with. In somebody with bad sarcoid, we start at 5 mg per kg per month. Okay, once a month. All right. So again, we're using it quite aggressively, and it works particularly well. Okay, for some of the critical organ involvement, particularly the neurologic involvement. Okay, so again, something to go to early if you have somebody with one of those presentations. Now again, if you're going to be an internist, you have to take care of all the other things, okay, that they can have difficulties with. So if you're on high-dose prednisone, we need PCP prophylaxis. We need to make sure that we treat them for their osteoporosis or protect them from that. They need their immunizations. Again, depression, fatigue, okay, need to be looked at. If they have pulmonary hypertension, we use antihypertensive medicines, and some patients have to go to lung transplant. And there are indications for that, realizing that sarcoid will recur in the transplanted lung, but it's much less severe when it occurs, okay, in those individuals. So we're back to our case, okay? Which one of the following would you do now? Okay, so that case, we're trying to find sarcoid, some place to prove that that's what they have going on. All right, so am I going to do an eye exam, CT of the lung, ACE level of the cerebral spinal fluid, brain biopsy, or bone marrow? Well, what we did was a CT of the lung, all right, and the CT of the lung showed that they did have hyaluronopathy, okay, that wasn't picked up on the chest x-ray. We did a transbronchial biopsy, and we found the non-casein granulomas. We did an eye exam. It was negative, so that didn't help us. And we did do a CSF ACE level that was quite high. So again, we felt confident in our diagnosis. So we gave him high-dose pulse steroids, gave him Cytoxan, okay, and then followed that with infliximab. He stabilized. We didn't reverse much because he had had 4 years of misdiagnosis, okay, and we stabilized him, but as I say, he didn't get a lot of function back. So in summary, okay, sarcoidosis is common with, I hope you realize it has protein presentations and manifestations. It really is the great imitator, okay? It needs to be on your differential of most things. Evaluation for extrapulmonary organ involvement is critical because it can support our diagnosis, but also helps gather reasons for therapy. And again, our therapy is directed against both the acute and chronic disease, and we use steroid-sparing agents for patients with chronic disease. And as I said, my talk was Hutchinson, sarcoidosis from Hutchinson to Russell. Okay, so this is Bill Russell. You all are a basketball town. I'm sure you know Bill Russell. Bill Russell is a former basketball player for the Boston Celtics. Okay, he was a great in his day. He has sarcoid. His daughter has sarcoid. They're spokespeople for Stop Sarcoidosis. We need more research to find out what the etiology is. So again, thank you very much. It's a great honor to give this lecture. Thank you.
Thank you, Dr. West. That was great. Great review of sarcoidosis. A disease that I care a lot about, in part because we see a lot of these patients, in part because my mother had sarcoidosis, my uncle had sarcoidosis, and Annette had sarcoidosis. And I'm still waiting for mine, and that's why I don't have to. So I was gonna ask you. So when Mike Iannucci was here several years ago, one of the discussions that we had was this idea that we probably should stop looking for the cause of sarcoid, because it just seems, based on the data that we have, is that it just seems that people who are exposed to any given antigen with the appropriate genetic background and predisposition will develop the syndrome, in a sense, and that it will be multiple causes depending on the genetic background. What do you think about that?
No, I think that's exactly so. Okay, very similar to what we see with rheumatoid arthritis or lupus, that whatever the inciting event was years earlier, okay, and now we're seeing the clinical manifestations down the way, all right? But again, there's still a group of people that believe that TB is playing a role, or that P. acnes are playing a role, and they're doing antibiotic studies, okay, to see whether that's changing the course, okay, at all. We'll have to wait for those results.
Questions, comments? This was so good. Let's start over
do they have the same prognosis as far as recovering, or? Yeah, a lot of times then central nervous system involvement, yes, but a lot of times it'll occur together, and you got to make sure that that's not happening. Right? Yeah. Yeah, we all are. Oh, hopefully in another 50 years we'll know, right?
The take home then, you'd say for general medicine approaches, the best thing you can do is have low threshold for SCC and eye.
Well, if you can't find it elsewhere, but I think the take home, all right, is to keep it on your differential. Okay, it needs to be on whether, no matter, and because it can present, okay, and imitate so many other diseases.
So your patient didn't progress, but they're getting better.
Correct.
Are there any really controlled studies to say that any of these treatments really prevent progression?
Yeah, the controlled studies, okay, that's the key word, okay, here, okay. So from controlled studies, no, all right, but from experiential studies, okay, knowing what the natural history would be if you didn't treat them, okay, by putting them on some of these, particularly the anti-TNF agents, okay, we now have evidence that they are not progressing. But that's compared to historical controls, okay, because it's very hard to do a controlled study, okay, when somebody's going to have this severe a disease. Yeah, rheumatoid factor will be positive in probably about 20 to 30% of sarcoid, but at low levels and not associated with anti-CCP.
You guys have fallen in love with hydroxychloroquine, and the pulmonologists have fallen in love with Microphil.
Yes.
But I find myself spending an enormous amount of time avoiding giving anything.
Yep.
You?
No, I agree completely with that.
It just seems that because we have little data and we can do a lot of harm,
Right.
Unless there's significant symptomatology that we just can't control elsewhere, I think that one of the take-home messages that I usually use is try to avoid giving medication unless you have the big issues.
Right.
Significant pulmonary involvement, neurosarcoidosis, hypercalcinuria, liver involvement, that sort of thing.
Exactly right. No, I agree. And at referral centers, okay, like we are, we're obviously going to get a skewed population of that. But we tried to, again in the talk, give you guidelines for when are you going to put them on prednisone, all right, and then when are you going to go to immunosuppressants. All right, when I put somebody on prednisone, I'm also thinking about putting them on hydroxychloroquine, all right, to help, not alone, all right, but in conjunction, all right, to help be an adjuvant to help get them down on the prednisone.
Questions, comments? If not, then we have a tradition here of sending people home with a Louisville slugger. Okay?
Perfect.
And it helps with faculty that are unruly or spouses sometimes. My wife uses one of these with me.
Yeah.
And so this is important because I think our goal is to have one of these at every institution throughout the United States so that you remember us and remember our colleague, Dr. Neustadt. So Dr. Sterling West, 2017 Department of Medicine, Grand Rounds, Neustadt Lecture, University of Louisville, March 9, 2017. Thank you, everybody.
Thank you. Thank you very much. All right.
It's so good. They won't let you on the plane.
Oh.